27% of vertigo patients experience anxiety. Stay tuned because today you will discover the correlation of primitive reflexes and vertigo, and you will learn brain-based approaches to help positional vertigo patients. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions so you can get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Nick Moss is a highly qualified and experienced health practitioner with well over 10,000 hours of clinical experience assisting people through a wide variety of health challenges ranging from chronic pain, autoimmune, trauma and anxiety, digestive metabolic disorders, and posture and injury rehabilitation with his brain-based approaches. He's the creator of the Functional Neuro Health education system that trains practitioners and his methods worldwide. Today, he'll be sharing with us the vertigo-anxiety connection, a clinical approach. Nick, thank you so much for joining us as a presenter on the Virtual Neurology Summit. Please take it away.
Today, what we're going to be talking about is the vertigo-anxiety connection. And we're going to talk about the immune system as well, but basically, this is something that holds weight in a bit of the research. There's also something that I've seen over and over with working with a very common complaint that you would see within a functional neurological skill set, which is vertigo. You don't even have to look at the research to know that there is a connection between vertigo and anxiety, but the research does have some supporting evidence there. So that's what we're going to talk about today. So as per this paper here, it says vertigo and dizziness are common symptoms in the general population with an estimated prevalence of between 20% to 56%. That's quite a large number. And with a brain-based skill set and a functional neurological skill set, you're going to see this case presentation a lot. And with the skills that we have, perfectly suited to create some great effects for that. But we have to look at the nuances that come with this presentation as well. That's what this whole presentation is about. So the key brain zones and pathways that are involved with vertigo, we have the autonomic system. We know that's the sympathetic, parasympathetic. Any disturbances within that system is going to potentially be an input into why someone has vertigo. We have the cerebellum, we have the limbic system, we have the receptors in the mechanoreceptive system of the musculoskeletal system. We have, of course, have the vestibular system, which always gets blamed, but sometimes it's not always the direct cause. We have the brainstem. Obviously, the vestibular system lives in the brainstem, so that's an area we want to have a look at. And then we have the all-important ocular system in terms of the eye movement system. So that's probably no news to people who are already practicing this skill set. These are the pathways that we'd want to have a look at. We'd also be looking at the position of the head and the neck as well, and the cervical stability. Okay, so in my practice and what I've tried to do over the years, and especially as an educator, is try to break things down so we can put them into packets of information so we can separate all the complexity within clinic and organize our thinking. What we might see when it comes to vertigo is we may see positional dominant vertigo, immune dominant vertigo, and limbic dominant vertigo. The main ones we're going to talk about in terms of the differences are the positional and limbic. We're also going to touch on this one here. So positional is your BPPV. The position and acceleration of the head are deemed as a threat by the nervous system. That all makes sense. So essentially the inputs of the head and the head in space and how that's all being connected by those previous pathways on the previous page. Then we have immune vertigo, which is actually, as we know why, it's rising more and more with post-COVID sort of symptoms. Underlying infections such as viral or bacterial, which may throw the autonomic system into disarray and cause hypertonic basal nuclei. And then we have limbic dominant, which is primarily conscious or subconscious emotional drivers triggers. This is where it becomes a little bit tricky, and that's what we're going to touch on today. And really, most people will present with elements of all this, but if you can try to find out what is the main driver for your patient or client, it's going to set up for clinical success. Okay, so standard approaches for positional vertigo, you'd look at the vestibular system, the cerebellum, eye movements, cranial nerves in general, and then you'd look at cervical stability, potentially primitive reflexes. In our system, we will look at the primitive reflexes and the cranial nerves first anyway, and then we'll start to get a bit more specific about what's going on in these specific pathways. Hope that makes sense so far. And some of the primitive and postural reflexes, which are associated to balance and equilibrium, we have these reflexes that set up our postural system. I'm sure you know all about this, Krista, here. So you got the cervico-ocular reflex, vestibular spinal, vestibular ocular, vestibular colic, and the riding and tilting reflexes. And that's just like our automatic postural responses. The things that format them, again, we're going to throw it back to the primitive reflexes. For years, I thought about what is the main pathway. They're all pathways in the system and very important, but if the brain chose to do primitive reflexes first, I'm like, there's got to be a reason for that. It's got to be pretty damn important. The primitive reflexes format all other reflexes in all other parts of our neurology. So the Moro reflex, the ATNR, the STNR, the TLR, Landau, etc. All these reflexes and the integration of them or the disintegration of them will have an effect on all these, and then they'll have a further effect out into the postural neurology system. So I'm just going to go quickly through a classic sort of positional vertigo case. And just so what I would see, if it's just positional vertigo, is quite good results in pretty quick time, like 1 to 3 sessions. So this guy, we had a 38-year-old male complaining of vertigo and dizziness for a few weeks, unknown origin. He had migraines though for a semi-regular and for a long time. Relevant history, car crash 16 years ago. Symptoms can worsen or improve after eating. That was interesting. Maybe vagus nerve, maybe some gut issues. We know that head injuries can cause gut dysfunction. He was seeing a chiro, I think it's just a standard, typical sort of chiropractor with minimal relief. Current symptoms are of unknown origin. Yeah. Baseline assessments, we did the Fukuda step test. It didn't really show much. It was just moving slightly to the left. Romberg's, just slight tilt to the left. So nothing really much showed there. When we dived a little bit deeper into our approach, the functional neuro health assessment, we looked at reflexes and we had the fear paralysis showed, which means that also the Moro, the TLR, STNR is also going to show. And this is the top reflex here. Is all clustered together. Some cranial nerves are 1, 5, 8, and that related back to the vestibular system here. Eye movements of pursuits, optokinetics, and VOR. So we assessed, this is what came up in our assessment, we corrected them. And these were the results. So the client noticed about 50% improvement in symptoms after the first correction, which would have been up here. And the presenting symptoms were fully resolved at the end of the session with no residual symptoms. And I think that's all he did. I think he just did one session. We had a bit of homework. A lot of times it went back to the pons in the brain, which houses the vestibular nuclei, as we know. So that makes sense. We gave him a little bit of homework. It was just we found out what his system could tolerate. It was just some VOR drills, up, down, left and right. And that was his main homework for a few weeks afterwards. Another positional vertigo case, this one was really interesting. So this client presented to me with severe vertigo worsened by turning the head to the left. She'd had it for 3 years. She'd gone down the functional medicine path, but with no luck. And when I was taking her history and I said, what causes it? She goes, when I turn my head to the left. I said, oh, that sounds like it's positional. She goes, no, it's not positional. There's sometimes I'm like, okay, let's just bring you in. We'll have a look. And the assessment showed like a Purkinje cell lesion in the left side. So basically her vestibular system was firing too much to the left. Use a VOR cancellation drill, which basically swings her brain back to the middle. And 2 repetitions, she did that. And I said, look to the left. She looked to the left. And it was the first time she wasn't in a washing machine when turning to the left for 3 years. Looked at me with like wide eyes. And I was like, and I was also as surprised. I was like, okay, I didn't think it'd be that easy. And that was all we did. That was classical in that case. In that moment, she'd done other work and she needed the position of her head to be corrected. And it was a quick response. Okay. That was pretty much all we did with her to stabilize her. I tried to do other stuff, didn't really work, but that was the main thing. Okay. Now let's look at the vestibular and limbic connections. Just neurologically in the brain, there are a lot of connections. There are a lot of pathways that do connect. The limbic system, we know the vestibular system is in the ear. It's what we were just talking about. The limbic system is the emotional system of the brain, or the threat system. And there's a pretty good paper here, but the main part I picked out was considering the extensive networks between vestibular and limbic system, it is likely that vestibular stimulation techniques may be useful in influencing emotions. That makes sense to me, but it also could happen in the reverse order as well. It can go, if the information flow can go that way, the information flow can go the other way as well. what we're going to talk about as we move forward is the emotional impact on the vestibular system, because we can address emotions through targeting the vestibular system. But what about the other way around? Here's some known pathways. We have information coming in through the sensory system into the vestibular nuclei, goes into the parabrachial nucleus and the amygdala, and then you've got the hypothalamus and the HPA axis, and all that whole system kicks off there. And then you've got the NTS, which is related back to the vagus nerve. And so that's all just one continual loop of information going in all directions. So we can see when vestibular symptoms or even anxiety symptoms can become chronic, everything just sort of gets clumped together within the system, and it can be hard to untangle. And that's what we're going to try and do here. This one just talks about the prevalence of the different comorbidities, such as anxiety, positional vertigo, and vestibular migraine, and that there's a high prevalence with comorbid anxiety with these sorts of presentations. This is what we're talking about here. So I had clients that would come in and we'd stabilize their neurology that was related, their vestibular system, their eyes, etc., but they still had the symptoms. And I'm like, okay, what's going on here? And this paper sort of points to it. It says chronic subjective dizziness. So it's subjective to the client, characterized by persistent non-vertigo dizziness, unsteadiness, and heightened sensitivity to motion stimuli that may last for months to years after the events that have caused it. And we'll often see this in like post-concussion cases as well. Okay, so this paper also showed altered connectivity between the insula, the different parts of the insula, the parietal insular cortex, the occipital cortex, and the anterior cingulate. So it's like those brain structures that are involved, and they have heightened sensitivities with this sort of client, which makes sense as we move forward. Here's a limbic dominant vertigo case presentation. This was an extreme case. 40-year-old female presenting with severe dizziness caused by post-concussion. So she had all the things that you would have for post-concussion, dysautonomia essentially. And then for her, anxiety is a huge trigger. Like, she has anxiety over her symptoms. We've seen this a lot. And that can be sometimes the thing that triggers the whole pathway. She had 4 car accidents, and she was also involved in the London bombings on the tube. So I think that's where it all started. She has quite a bit of trauma as well, and a pretty extensive medical history. So the initial treatment and responses, she was initially being way too overstimulated by too many different modalities at once. She was enrolled in a medical concussional program at the Epworth Hospital here in Melbourne with rehab and physios and exercise physiologists. She was doing vision therapy with a behavioral optometrist, and then undergoing a strict and intense gut protocol for SIBO. And she was trying to see me as well. And it just 2 steps forward, or 1 step forward, 3 steps back sort of approach. So as a result, her neurology was being way too overstimulated. So what worked is it just got to a point where she decided to stop everything and rest for 1 to 2 months. Then she resumed therapy with just myself. And within 2 months, probably less than that, she was stable pretty quickly, but she was very stable. Within 2 months, she was in a better position than the previous 7 years. And her neurology was relatively stable at that time. And then I advised her to recommence the rehab with the other practitioners that she was with. So she had a bit of a clean slate, not too many inputs, and she didn't believe she'd ever be better again, which was quite interesting. So we had to work through that. What worked? This is what we do, like pretty similar approaches: reflexes, cranial nerves, cervical stability. That was huge. Lots of emotion work around their mindset, her perception of herself and her beliefs. We also had to do quite a bit of work through the lymph just to get it draining from the brain, and graded breath work. She had a bad experience with breath work before. So once we found the right type of breath work, which was just CO2 tolerance breath work, then we started to build her up from that. So her system was being built up from the ground up again. So that's what worked. And there's many cases of that as well, where I've had clients, I test all the neurology, good, takes 1 to 3 sessions to stabilize the neurology, and then they've still got symptoms. Okay, I'll test everything. It still seems to be stable, but they're experiencing the symptoms. And I would point it back to that chronic subjective dizziness. And it's like the sensitization of these pathways. So the approach for that type would be And this is depending on you. If you don't have this in your skill set, then you would want to be referring out as well. I'm lucky I've been trained in this stuff, and we have some approaches with our tools as well that we can clear through some emotional patterns. And every time you do that, it releases a load of sympathetic input, and that restores the bandwidth. Integrate the brain through the brain nuclei that we just mentioned before, getting them all firing and working together, and then limiting belief and coaching, identifying where their language is around their condition, what they believe. If you can identify that and work through that, then that can also help them. Again, if you don't have that, if you have something, you might need to refer that to someone, or maybe have someone like that on your team already. That's awesome. But even just being able to question and empathize with the client, patient is key here, and try to understand what their conscious goals are as opposed to what their nervous system's goals are. One thing I look at in the initial session is, okay, what do you want to feel when you walk out that door? Like, how do you want to feel? What's your goal today? And they say, oh, I want to feel better. Okay, how would you feel when you feel better? I'd feel free, or whatever it is. They'll use some language, okay? Okay, great. So that's what you want. Awesome. Now my job is to work with your nervous system to see why you can't in that state in the first place. Like, why can't you get there? Because often there's a lot of things going on within your neurology that are stopping you from consciously achieving that state. I find that setup really helps the flow of the treatment. So anxiety-induced limbic vertigo. So neurology can be stable, but emotions act like a tripwire that bring up the whole cascade of sensory symptoms. So there could be a thought attached to a perceived threat, like an anxiety trigger or even a body trigger. Yeah, so there can be an emotional reaction to a physiological sensation. This is anxiety, and that can cause the entire symptom picture to be brought back into conscious awareness of the patient and can result in catastrophizing. We all know what catastrophizing is. Or I'll never get better, it's come back, blah, blah, this doesn't work, no one can help me, things like that. Because what often happens is, their mind, or either a conscious or subconscious aspect of their mind, has neurotagged a certain physiological sensation. Maybe it's heightened breathing, maybe it's their heart rate, maybe it's the dizziness itself, maybe it's some visual issues, maybe it's tightness in the neck, whatever it is. There'll be some sort of physiological sensation, or maybe a whole packet of it. And then their mind will perceive it and then go through its whole cascade of thought loops, which are associated to that feeling, which is really a neurophysiological response. And then they'll have certain behavior, and that'll give them a result. So that's why it's a great approach to have a brain-based approach first. You stabilize the system. Their feelings are going to change, their emotions are going to change, their thoughts are going to change. But if we're stabilizing their neurology and symptoms are coming back, it's almost like the brain has a memory of the symptom picture, as opposed to, there may still be work to do with the neurology, but there's almost like it's almost like the symptoms become a protective pattern for the client. So this is where this different approach comes in. The key pillars is a conscious retraining of their own physiological responses, bringing that awareness to it. Did you notice that you felt it here, and then that was attached to an emotion? And then how did you think about that emotion? Did you want to avoid the emotion? Did you want to avoid that feeling? Or did you want to get something else? Did you want to, I don't know, so sometimes people, they feel something in their body that they perceive as a threat, they'll get afraid, they want to avoid it, so I've got to run away, I've got to think, and everything about their body, their perception is everything in their body, which is actually normal to someone who's not suffering this, becomes a threat. So it's like sometimes you have to do conscious retraining. Giving an example and talking them through their perception of their own body, so they don't bring the whole symptom picture back themselves. So it's a bit more of on a psychological, biopsychosocial sense. But for some people, that's going to be a fair chunk of what you're working with, in addition to doing the neurological work. So subconscious drivers, we have a way we can look at that as well. And then conscious self-perception is what we're talking about there, like reframing, like where they learn that their body is unsafe. Was it from Dr. Google? Was it from other sources of media? Was it from other other professionals that they've been through beforehand? We know that their family, of course. Oh no, this means that. These are all things you got to look at. Okay, hope that makes sense. So just a little bit of a difference there with the approach. We'll still always approach vertigo as if it's positional anyway, and address it that way. But then we have immune dominant vertigo as well. and then depending on your skill set, how you can interact with this will be different. We know the vagus nerve is really the master chief commander of from a neurological sense, the immune system. It holds the anti-inflammatory switch. And so anything that can impede that flow there will be potentially affecting it. We know whenever there's a head injury, which often causes vertigo, that's because of that gut-brain axis, that NTS pathway there is interrupted. So obviously cervical stability, particularly C1. So chiros have got an advantage here because you can look at that and make sure that pathway is all flowing well. So I'll be looking at it mechanically. You've got different stimulations that you can look at for that as well. I find with some cases of vertigo, working on the vagus nerve can actually, if it's not immune dominant, can actually not be the most ideal thing. But if it's immune dominant vertigo, we can also look at lymphatics. How's the lymphatic system draining from the head? Often the system stops draining because there are hypertonic muscles around the head and neck. So like the pec minors, often they can become in spasm and they compress over these thoracic ducts here. So any way you can open that up, and you get the flow from the brain down into the rest of the body. And then you may need to refer on to functional medicine, or if you have that in your toolkit, you may need to use some functional medicine to stabilize the immune pathway responses, the Th1, Th2, Th17 responses, and see if that has an effect on that. And if it's immune dominant, it'll be the immune work that really stabilizes it for that patient/client. Hope that makes sense. So basically, yeah, it's just saying the cause of dizziness determines our long-term approach, because we're going to initially treat it as if it's positional, which is really changing the inputs. The more chronic it becomes, especially when it's anxiety dominant, it's more about the processing. So this is like conscious self-perception, the emotional layers, and then the integration of the different brain nuclei, so within the brain itself, which will change the output. And then once that's stable, then you can start to drive input, which would be for your corrective exercises or your rehab drills. I think understanding if you don't get that good response initially from the positional work, then it's looking at potentially it's this chronic subjective dizziness that's at play here, or maybe a deeper immune issue. And so just things need to be addressed properly. So that's probably the main thrust of this talk here, is the effectiveness of any therapy depends on the basis of the problem and our ability to find it. So this is our approach from a neuro sense. We would just have our normal baseline assessments. Initially, a client first comes in, baseline assessments. We would downregulate the sympathetic system if that was at play. We'd do a bunch of manual procedures for that, and then we'll start assessing, correcting, and reassessing pathways. And that's the flow of session. And we'll correct a bunch of pathways, and they'll walk out feeling pretty good, different. And then each session we'll test our work as it moves forward. I don't know what types of practitioners we have going through here, but here's some questions that you may want to have a look at in your clinical history, just to give you a bit of something to work with when you're working with vertigo and anxiety, or you've got a presentation similar to this. Childhood development's a good question. So interruptions or delays in childhood development, or even stress and trauma through gestation and in the initial few months will, often retained primitive reflexes. They never inhibited. That gives the patient a lower baseline threshold to stimuli. They become more sensitive. Big one, this is obvious, previous concussions or whiplash. Most people are looking at this, especially these days. Most people have them in their history, but they've forgotten, or sometimes they have multiple, and then we're looking at like how close are they together, what happened at the time of the concussion, was there stress going on at the same time, etc. The area of impact is key, because that can then focus our neuro rehab. We're looking at the coup and the counter coup, the initial impact, and then the second impact. So if it's front to back, it's frontal lobe, occipital lobe, the hit to the side, it's the temporal, bridal, etc. And that will determine your rehab if you have that in your toolkit. Exposure to psychological trauma. The research is showing that psych trauma, sustained and severe psych trauma, is perceived as the same physiology as a concussion. The earlier, more consistent the exposure, the more sensitized the limbic circuitry becomes. And then so we more focus on the limbic system. So this is just a bit of information that you can glean from your history, which you could be taking online. Symptom behavior, does it get worse with stress? The more it's worsened by stress, the more likely it's limbic dominant. Worse with fatigue, it's maybe just those systems aren't operating so well, the neural hierarchy. If it's better for movement, there maybe needs specific inputs afferent inputs, more stimuli, information from the body, stability, joints, etc. That's going to help them. And also, what do they believe about the condition? So I touched on this before. Pay attention to what stories they're saying. Who are they believing? How much are they consciously overriding their felt sense? So, for instance, like some people, they're getting better, but they don't perceive that they're getting better, even though when we test their physiology's changed, but they can't perceive that they've changed. That's sort of belief and identity work. Even just paying attention to that is and listening to how they speak about themselves, I think is a interesting way to look at things as well. So stress perception, threshold, and effects on the symptoms. So how much impact is perceived stress affecting their condition? So that's, again, going back to the more stress affects, the more likely that sympathetic system and the limbic system is sensitized. And so we want to try and help them out of that. Our approach's summary is positional. We'll integrate the vestibular system, the cerebellum, the brainstem, the primitive reflexes, that's PR, and then cervical stability as well. Immune, we'll look at the vagus nerve stimulation, lymphatic system, mobilization, viral and bacterial protocols. And then for limbic, we'll look at emotions, limiting beliefs, reframing. We'll look at nutrition for the brain as well, so specific nutrition that targets specific neurotransmitters, mindset training, brain integration, so basically integrating all those brain zones there. So that's my talk there about this, and hopefully that makes sense. And yeah, that's the way we do things. And this is something that I've had quite a bit of experience with over the years. And some of it's, looking at the research, some of it's just seeing it from many different clients. And I think we can help a lot of people definitely with the brain-based approach, but then once we understand all the other bits and pieces, if we have that in our toolkit, we can help it. If not, we can associate with the relevant professionals to get help for this patient or client.
Wonderful.
Yeah.
Nick, thank you so much for this great trusted protocol and approach when it comes to patients with vertigo who are also associated with having anxiety. All right, so you talked about the prevalence of dizziness being between 20 and 56% of patients. Key brain zones associated could be the autonomic, cerebellum, limbic, receptors, vestibular, brainstem, oculomotor, cervical stability. And when we talk about positional, so positions and acceleration are deemed as direct threat to the nervous system, with immune underlying infections impacting the autonomic nervous system, and with limbic, primarily conscious or subconscious emotional drivers and triggers. With BPPV, this could be vestibular, cerebellar, eye movements, cranial nerves, and primitive reflexes. Some key primitive reflexes, the Moreau, ATNR, STNR, TLR, and the Landau. And then integrate to postural reflexes, so such as cervical ocular, vestibulospinal, VOR, vestibulocholic, and the writing reflexes. And you gave us a couple of great cases. And with these different cases, you showed how the effectiveness of doing VOR up, down, left, and right, and then VOR cancellation drills with another case. So demonstrating some ways of stimulating that vestibular system and helping patients with vertigo. Now, with vestibular limbic connections, so vestibular stimulation influences emotions due to the extensive network of the great research study demonstrating that correlation. With the vestibular nuclei, then we have the parabrachial nucleus and the amygdala all being associated, and that can stimulate the hypothalamus to the stress axis, as well as the nucleus solitarius to the autonomic nervous system. And comorbidities, positional migraine, as well as anxiety for patients suffering from vertigo. And chronic subjective dizziness. So this is a great point as well, understanding that the vestibular disorder due to hypersensitivity of emotions to the events that caused it. So there being a correlation with the insula, the occipital cortex, and the anterior cingulate cortex. You gave a great case and how you worked with them with primitive reflexes, cranial nerve, cervical stability, emotional release, mindset, working with the limp, and then graded breath work, that being a successful approach for the patient. So when it comes to emotions, clear emotional patterns with integrating the brain, integrate the brain nuclei, and then limiting belief and coaching. So identifying clear limiting beliefs around their symptoms and suffering. So for example, showing empathy to the patient. And then I liked this question that you asked, how do you want to feel when you leave today? So then asking them how they want to feel and then understanding what the block is for them feeling that way. And then anxiety-induced limbic vertigo, emotions act like a tripwire that brings us a cascade of sensory symptoms. This can result in catastrophization. And for patients who've experienced vertigo, this can feel very debilitating to them. So they want to do everything that they can to avoid it from triggering, but then being obsessed with it can actually lead to triggering that emotions associated with it. So, key pillars, subconscious drivers plus conscious self perception, so reframing, and then may have craving strategies or avoidance strategies. And with clinical, you gave another example of a different type of vertigo, which could be due to immune. So, looking at the vagus nerve, looking at upper cervical stability, lymphatics, how's the lymphatic system draining, and then functional medicine may be appropriate as well to support the immune system. And then causes of dizziness, so input and processing leading to outputs. If positional doesn't work, look at chronic emotional triggers or immune. And then ultimately, the flow of your sessions, including a baseline assessment, sympathetic downregulation, pathway assessment, calibration and correction, and then reassessment. And for the case history, great things to consider: retain primitive reflexes. Do they have a low baseline threshold of stimuli? Have they had previous concussions or whiplash? Have they had exposure to psychological trauma, which has sensitized the limbic circuitry? Symptom behavior, such as stress. What do they believe about their condition, so their belief identity? And then stress perception. So, what's that threshold of stress effects? And ultimately, you shared with us approaches for positional, immune, and limbic associated vertigo. Really great presentation. Thank you so much. Couple questions for
Thank you.
you.
Yep.
So, when you're working with patients, and I know you said that you have specific training and strategies working from an emotional component with patients. So, how do you prevent overstimulating a patient's neurology if they are particularly emotional at that visit? What are some things that you look for that would either say, okay, perhaps we need to address the emotional component first, or we want to start with lighter stimulation to prevent overstimulation for the patient? What are some of those cues that you look for?
Yeah, good question. And so I suppose when I run you through the 5-step process there, that's the reason why we have step number 2, we have the sympathetic downregulation. So we have a bunch of sort of manual techniques that we use. It involves like gentle rocking. We also have a manual procedure on the phrenic nerve, which is the nerve that controls the diaphragm. We find if that nerve is off spasm, it just automatically resets their body. That usually works for a lot of people. So what we do is we take that time initially to understand the person, like before we do that. So we've got the intake, they're sitting down. What I'm trying to do is actually really understand how that person is operating in their mind. And then as that, you're getting an insight of, okay, yeah, obviously you can tell when someone's quite sensitive. The more sensitive they think they are, the more time we spend in that sympathetic downregulation phase, which is body-based sort of downregulation. Gentle rocking harmonic technique has been shown to put the system into that parasympathetic response. We also open up the diaphragm. We may do some breathing, slow breathing. And then we may even sometimes do vagus nerve stimulation, which has the same sort of effect. Initially, for that first sort of half an hour or so, we work on usually hour sessions. And then once we're ready, we will then start with the pathways that have the most downstream effects in terms of effect on the stress system, which is like those primitive reflexes. If they're there, we will correct them. If they're not, that's fine. We just move to the next thing. We just go through like an assessment sheet. But yeah, the more likely they're sensitive, the more time we spend down regulating that system. And yeah, also, what else would we do? We do have an emotional process as well. So if someone is super triggered, they're feeling really triggered in that moment, we can actually get them to visually go through, or with a felt sense or a visual sense, go through the emotion and then collapse it down from the body. But often that doesn't come up that much. If we do that step 2, where we really set up the system to be able to take on the inputs that we're going to do, then the more thorough we are with that relative to the client, the better things flow.
Mhm.
So,
Yeah, I
yeah.
love that. And that's a great way of setting it up and having that flow so you know what to look for, as well as following that flow in terms of best patient care. I always say that you can always add more, but you can't take away. So if you've
Mm,
overstimulated a patient, then you can't take back from that session right there, but you can always downregulate first and then slowly add more to get that stimulation to the nervous system. Really
yeah.
great. And where can we learn more from you and about your company?
Yes, my business is Functional Neuro Health. I'm very active on Instagram. That's where I do a lot of my work there. So if you follow me on that, I've got various links that you can follow through there. I've also got my website, functionalneurohealth.com. And I've just got education practitioners. I do have education for general public as well, but for the moment, I'm focusing on just teaching what I've developed over the years to multimodality practitioners. And there's a link on the website where you can find education. If you follow me on Instagram, there's also a link to watch some free training. So I've got some free training, like a 3-video series on what it is that I do, a bit of a deeper dive into that. And then if that's something that resonates, then schedule a call and we have a chat and we go from there. Yeah.
Wonderful. Thank you so much.
Yeah.
And as we wrap up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Nick for his excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.